All right, party people, we are back at it with another one. Let's get it. So we've got a 70-something-year-old female with a 1-year history of urinary incontinence. She has to sprint to the washroom whenever she puts the key into her front door, and her meds are a calcium channel blocker. Now, the key in the door description is a buzz phrase. This is a classic trigger for urge incontinence. Now, the option choices are up on the screen. Please make your selection. 3, 2, 1, boom. Let's get into why the correct is correct and why the incorrects are incorrect. So let's start with pelvic floor weakness. This is an incorrect answer. This is for stress incontinence, not urge. So classically, what you will see is a multiparous woman with weakened pelvic floor muscles. They might even mention a downward mobility of the vesico-urethral junction. The clinical scenario that you will see is urinary leakage with laughing, coughing, or sneezing. First-line treatment is Kegel exercises, and if that fails, the next option will be a mid-urethral sling, a surgical option. Now, importantly, you do have to know that you do not treat stress incontinence with meds. Anticholinergics, like oxybutynin, or a beta-3 agonist like mirabegron, are incorrect option choices for this pathology. Next up, overflow incontinence, again incorrect. So here, the mechanism is that you have outflow obstruction, such as BPH, or you might have neurogenic bladder. This is commonly due to diabetes. Now, if diabetes is the cause, they'll also have to give you things like a HbA1c, which is high, let's say around 10%, 9%, something like that. If the patient has peripheral neuropathy findings, such as decreased pinprick sensation up to the knees, this is another classic indication. Now, for this, treatment depends on the cause. In the case of neurogenic bladder, you might be using bethanechol. This is a muscarinic agonist. This stimulates the detrusor contraction. For BPH, you're going to give an alpha-1 antagonist, such as tamsulosin or terazosin. You might also give a 5-alpha reductase inhibitor, such as finasteride or TERP. Now, in terms of residual volumes, a normal range is about 50 milliliters. Overflow incontinence, your residual volume will be around 300 to 400 milliliters. If the question gives you less than 100 milliliter residual volume, that is not overflow incontinence. As far as the calcium channel blocker, in this case, let's say it's nifedipine. This would be a distractor. The literature shows nifedipine can slightly increase residual volume, but bladder pressures don't really change. So yes, there's a weak association with overflow incontinence, but quite frankly, it's not the case in this vignette. Next up, bladder neck dyssynergia. This is a distractor. Dyssynergia is a distractor. The definition is the discoordination between detrusor contraction and sphincter relaxation. The causes for this could be spinal cord injury or multiple sclerosis. It can be associated with encopresis. This is the pooping of one's pants, but it's not relevant here. All right, so finally to the correct answer, detrusor instability. This is the correct option. Detrusor hyperactivity is urge incontinence. The patient's symptoms, such as keying the door or urgency after getting out of a car, are classic signs. Now, first-line treatment is an anticholinergic like oxybutynin. This is a muscarinic antagonist. An alternative option is mirabegron. This is a beta-3 agonist. Now, other high-yield associations you have to know for your licensing exam is that for multiple sclerosis, this is often tested with urge incontinence, not overflow, despite some confusion in a lot of the resources. On exams, when you see MS, they're talking about urgency and detrusor overactivity. But if they give you a patient with 400 milliliters of residual volume in their bladder, you have to be thinking overflow. So you can't just memorize things, you actually have to think about this on your exam. For perimenopausal women, this can also develop for urge incontinence. Sometimes this can be linked to vasomotor symptoms, vaginal atrophy, or idiopathic changes in aging. For younger women, let's say in their 30s, you can have urge incontinence, so then you have to be thinking multiple sclerosis. In older women, let's say in their 70s, this is often idiopathic detrusor overactivity. All right, let's spin the block and summarize all of this. So for stress incontinence, you're thinking pelvic floor weakness, and this is treated with Kegels or a sling. For overflow incontinence, you're going to be thinking diabetes for neurogenic reasons, or BPH, and you're going to treat them accordingly. As far as our patient for urge incontinence from detrusor instability, you're going to be treating this with oxybutynin or mirabegron. All right, that's it for this one. If you like the video, comment, share, subscribe, and check out my Substack at BigKahunaMed. All right, that's it for this one. Go crush it.